Hello everyone, my name is Derralynn Hughes. I'm Professor of Experimental Haematology at University College London and consultant in lysosomal storage disorders at the Royal Free Hospital, where I look after patients with Gaucher disease as well as other lysosomal storage disorders. And I'm really pleased today to be able to give this talk on Gaucher disease over the last 30 years. These are my disclosures relating to Gaucher disease. I'm currently the chair of the International Working Group on Gaucher disease, which started its life as the European Working Group on Gaucher disease around about the same time as the IGA, the International Gaucher Alliance, was founded around 30 years ago. And our organisations have been partners over those years in improving life for patients with Gaucher disease through advocacy, education and research. During this talk, I would like to highlight some of the advances which have presented themselves as opportunities to change care or to think about Gaucher disease in a different way. Some of my favourite papers and publications over the last 30 years. I'm not going to go right back to the beginning, but for those of you who might be new listeners, I will just explain that Gaucher disease is a lysosomal storage disorder. It results from the deficiency of beta-glucosidase within the lysosomes, and that results in the accumulation of its substrate, glucosyl ceramide, in various cells, mainly reticuloendothelial cells, throughout the body, and the various pathologies that we will discuss today. So, right from the outset, looking to the future, I'd like to set out that I would like to see early recognition throughout the world for patients with Gaucher disease, leading to prompt diagnosis, widespread availability of effective therapy, leading to a high and sustained quality of life. And as we go through this talk, I'd like to think about some of the areas where we are reaching that and perhaps some of the actions that we can take to bring us closer to it. To reach that goal of a better and sustained quality of life for our patients, I believe there are a number of building blocks, and we've laid great foundations for these with our communities over the last 30 years. I'm going to consider awareness, how that can lead to improved diagnosis, how delineation of phenotype can lead to a better understanding of pathophysiology, and ultimately better outcome measures can help us to design treatment more effectively. Awareness of rare disorders can be low. We know that although individually rare, many people within our population will suffer from a rare condition, and having a prompt diagnosis can make a difference to their overall outcome. Over the years, we've seen that many patients will take many visits to physicians or other healthcare professions and many years from symptoms to diagnosis. This was some work that was performed looking at the years taken to diagnosis over the last several decades, even more than 30 years. And you can see that many patients would take 10, 20 or 30 years or more to reach a diagnosis of Gaucher disease. There have been a number of efforts to improve awareness of Gaucher disease over the last 30 years. The differential diagnosis of Gaucher disease includes a number of haematological malignancies, and because many patients present with haematological problems, with low blood counts, with bruising and bleeding or enlarged organs, then consideration of that differential and inclusion of Gaucher disease is important to prompt diagnosis. This questionnaire survey amongst haematologists highlighted that awareness was low. Physicians were presented with a case of a 42-year-old male with symptoms relating to Gaucher disease, but many would consider the other differentials of leukemia, lymphoma and myeloma, for example, ahead of Gaucher disease. And this work has led to a number of campaigns to improve awareness amongst healthcare professionals that can speed up the time of diagnosis for our patients. So I think prior to the last 30 years and over this time, awareness has been low outside of specialist centres and has been driven by the availability of therapy. We've often had late symptomatic diagnosis. There has been some family screening and in some areas newborn screening, and perhaps a proliferation of targeted screening and raising awareness campaigns, all of which have led to an improved awareness. There has been really important work done by organisations such as Medics for Rare Diseases in including Gaucher disease and other rare disorders in the medical school curriculum. But overall, we do want to reduce reliance on awareness, reduce the chance encounter with someone who has heard about your rare condition and knows how to make the diagnosis, and to try to have more of a rational and standardised, targeted or generalised approach to diagnosis of patients with rare disorders. And for that, we can see that currently and in the future, there will be more embedded algorithmic approaches. New interventions required to help physicians identify patients with rare diseases through data which is acquired through normal clinical practice in primary or secondary care, using AI, machine learning and deep learning techniques. And I'm really pleased to be able to mention the work of my colleague from the IWGDD, Professor Shoshana Revel-Vilk, who has developed a machine learning model for the early diagnosis of type 1 Gaucher disease using real-life data. In her study, electronic health data was used to develop machine learning models which could speed up the diagnosis for detecting Gaucher disease, on average up to 3 years before the actual diagnosis occurred. But presentation of more potential cases of people with Gaucher disease through increased awareness and through machine learning and AI algorithms does require us to have prompt and affordable diagnostics. Currently, the diagnosis of Gaucher disease is based on decreased acid beta-glucosidase activity in leukocytes or cultured fibroblasts, and all by the molecular analysis of the GBA1 gene to identify mutations. This is often accompanied by a bone marrow examination showing foamy macrophages within the bone marrow or another organ that is biopsied. Measurement of enzyme activity is relatively quick and inexpensive. The genetics will give us better understanding of mutations and how these impact overall on prognosis of patients. However, sometimes the outcome is negative and patients are still looking for a diagnosis. And so the evolution of targeted resequencing and using panels which can tell us about other lysosomal storage disorders which may have a similar profile to Gaucher disease will also overall improve our capacity to make meaningful and accurate diagnoses. Over the last 30 years, we've seen the evolution of an increasing number of assays for testing blood spots, for evaluation of substrates. We've moved away from testing only the most common mutations to increase laboratory standardization, to understanding to some extent of the clinico-pathological correlation of how mutations might relate to disease phenotype. Diagnostics have become more rapid and scalable and affordable. There is still work to be done there. And as algorithmic approaches to help the diagnosis of patients with rare disorders become more common, then rapid, affordable, scalable whole genome sequencing throughout the world becomes more relevant. Out of raised awareness and the increased diagnosis of more patients with Gaucher disease comes the opportunity for better understanding of the clinical presentation, the phenotype, and the types of symptoms and problems that patients with Gaucher disease experience. We've moved from the understanding of the basic hematological features of Gaucher disease, including bruising and bleeding, enlarged organs, bone pain, and clotting abnormalities, to a more sophisticated and detailed understanding, which allows us to relate features to other markers of disease and the underlying genetics. In particular, features such as the heterogeneous and diverse presentation of bone disease have been aided by a really acute and detailed understanding of the phenotype. It has been a particular pleasure to work with my colleagues in Cambridge and in the other UK centres on the Gaucherite study. This has brought together 250 patients with Gaucher disease, including patients with non-neuronopathic and neuronopathic Gaucher disease, to an increased understanding and detailed description of the presentation, including the involvement of the organs, the bones, and the nervous system. For example, the Erlenmeyer-Flass deformity was present in 80 out of 125 patients. 62 patients required orthopaedic surgery. 25% of patients had undergone splenectomy, and the occurrence of symptomatic osteonecrosis was strongly associated with the removal of the spleen. And in fact, the hazard ratio for the first fragility fracture was nearly threefold greater in those also who'd undergone splenectomy. The Gaucherite study has also led to important insights in neuronopathic Gaucher disease. 27 patients had a diagnosis of chronic neuronopathic Gaucher disease, and in fact 4 of them were aged over 40 years. The neuronopathic features were often detected after Gaucher disease was diagnosed. This detailed understanding of the natural history and the problems faced by our patients will be invaluable in the development of new treatments and understanding their outcomes in the future. Our understanding of severity, prognostication and stratification of different presentations of Gaucher disease has been enhanced not only by that detailed phenotypic description from registries and databases, but also improved understanding of genotype-phenotype relationships and also of biomarkers, and in particular the development of lyso-Gb1 or glucosylsphingosine as a biomarker in Gaucher disease which can predict both the severity of the condition and response to treatment. And our understanding of phenotype has moved on from the effects on blood counts and organ volumes to also understanding some of the rarer and more unusual complications of Gaucher disease, such as the increased incidence of hematological malignancy, which, although rare, is still higher, for example, of multiple myeloma than in the general population. Work from case reports going right through to the groundbreaking meta-analysis of Professor Studansky have demonstrated the link between Parkinson's disease and Gaucher disease, both between people affected with Gaucher disease but also heterozygous individuals carrying the GBA mutation. And this has given us the opportunity to consider how rare disorder research might provide links to more common conditions. For example, how we can use our knowledge of glucocerebrosidase and glucosylceramide accumulation alongside synuclein in Parkinson's disease to allow opportunities for earlier diagnosis and potentially even treatment of people with Parkinson's disease and GBA mutations. So over the last 30 years, the phenotype of Gaucher disease type 1 has been well described, but perhaps the neuronopathic forms have been less clear. We've seen emergent phenotypes on therapy and increasing detailed phenotypic annotation through the registries, the industry-sponsored registries and databases, providing a central repository for phenotypic information and therefore the power of large populations to describe rare events and to understand those associations such as hematological malignancies and insights into other features shared with non-LSD patients, for example, Parkinson's disease. Out of the improved understanding of phenotype and clinical presentation comes with it a better understanding of pathophysiology, as we can stratify the different types of presentation of Gaucher disease and understand what drives that difference or heterogeneity. Our understanding has moved on from assuming that all of the features of Gaucher disease were related only to bulk accumulation of substrate in various organs. And as early as 1987, it was suggested that persistent antigenic stimulation in Gaucher disease affects all components of the immune system in our patients. The effects of many different cytokines have been explored. These are chemical messengers which provoke different effects on the immune system and can lead to varying pathology in Gaucher disease. And important work has suggested that some of these cytokines are chemotactic factors, which can lead to immunological cell invasion into various organs. And also a description of the deposition of complement, which is another component of the immune system, which in itself can drive the import of immunological cells into organs, and various other inflammatory effects which might cause some of the pathology which is demonstrated in our patients. A focus of much research over the last 30 years is related to bone problems in Gaucher disease, and this is a cause of much pain and reduction of quality of life, particularly in people who were diagnosed with Gaucher disease before the availability of treatment. Understanding the underlying causes, such as changes in cytokines, alterations of vascularity, and alterations in cellular factors, may allow us to understand how treatments work, to predict effects, and also to develop new treatments. Some work in our laboratory has demonstrated that a certain type of cell that circulates in the blood and goes into the bone can be more active in Gaucher disease. These are known as osteoclasts, and you can see larger cells in patients with Gaucher disease which are more active in breaking down bone. However, the work of others in a Gaucher disease mouse model and also in models of zebrafish have suggested that the defect may be in other cell types, such as osteoblasts. These are the cells which are responsible for the production of bone. And so it's possible that the impact of the storage material or sphingolipids on both osteoblasts and osteoclasts have an impact on bone disease in Gaucher, with some lipids causing an increased activation of the osteoclasts and more degradation of bone, and others causing an impairment of the growth of osteoblasts and therefore decreased bone deposition. And this allows us to think about how we might monitor bone disease and also potentially how we could intervene in bone disease outside of those elements of treatment which address the accumulation of substrate. Another important piece of work which might allow us to understand how the immune system is working in Gaucher disease is a finding from Professor Mistry's group that the clonal immunoglobulin in gammopathy, or patients with Gaucher disease and myeloma, recognises the lysoglucosyl-ceramide, so some of the accumulated substrate. Importantly, this was also found in people with myeloma who didn't have Gaucher disease, and so maybe another example of how a rare disease can give us insights into a more common condition and potential opportunities for therapy. So again, over the last 30 years, I think our understanding of pathophysiology in Gaucher disease has moved on from what I would call fishing expeditions with major conclusions based on populations that are very small and reliance on animal models, to a rigorous pathway evaluation driven by genomic and metabolomic technology, with an attempt to answer questions arising from the phenotypic evaluation and the opportunity for rapid translation of therapeutic potential. That translation to therapeutic potential should ultimately allow us to have better outcomes from treatment. But to do that, we need to understand how to measure benefit. In clinical trials, there's a hierarchy of outcome that ranges from pharmacokinetics and pharmacodynamics through to biomarkers and surrogates, and then those things which are more important to patients, such as how they feel, how they function, and then overall survival. But of course, the ease of measurement is inversely proportional to the importance to patients. For example, the measurement of blood-borne biomarkers can be used and standardized in clinical trials. They can give a good reflection of what is happening to the substrate and potentially the pathophysiology of the patient. But it can remain unclear as to how this translates to overall clinical benefit. We've had a proliferation of biomarkers. Some have been around for many years, such as the reciprocal platelet count, acid phosphatase, and organ volumes. And some have been developed over the last 30 years, including chitotriosidase, CCL18, and PARC. And recently, glucosylsphingosine developed as a biomarker which can be used, which reflects not only substrate reduction, but also potentially effects of pathophysiology, such as those on the immune system that I've described previously. So it's important that we understand how data generated from biomarkers and other surrogates relates to data of clinically meaningful endpoints and patient-generated data. The IGA has been instrumental in setting up and leading Guardian as a database of patient-held data. This is really laudable and I think a very important development in putting the ownership of data and of research back with patients. There's also been development of patient-reported outcomes, specific outcome measures for Gaucher disease, for example of that by Debbie Elstein and colleagues as a way of measuring the impact and the relevance of all of those surrogates on clinically meaningful outcomes. Outcome measures have therefore moved on from being surrogates of unclear relevance and unclear minimal clinically significant effect to perhaps newer patient-reported outcomes and new biomarkers and demonstrable and relevant clinical effects. There is still much to do to develop a framework for standardization so that clinical trials can be designed so we have the very best outcome measures which really judge the efficacy of new developments for the benefit for patients. And finally, out of better outcome measures come better therapies. I'm not going to rehearse in detail the history and development of treatments for Gaucher disease, but I think it is important to mention that this has been a long journey from bone marrow transplantation, demonstrating that replacement of missing enzyme was effective, through to the early pioneers of enzyme replacement therapy with alglucarase and imiglucarase, the early development of substrate reduction therapy, then alternative formulations of enzymes with veloglucalase and taloglucalase, and now alternative substrate synthesis inhibitors. Now, in many parts of the world, biosimilars are available, and people are also using other medicines such as Ambroxol, which have been approved for other indications and repurposed, with evidence perhaps coming from individual case reports. In this context, I think it's important that the patient organisation and the IGA has a strong voice in understanding how different treatments are used. And to this end, the IWGDD and the IGA partnered in producing a position consensus document on monitoring and best practice of patients who switch between treatments. The industry-sponsored registries have proven invaluable in collecting data and improving understanding of the impact of treatment on patients in the real-world setting. This is an important paper which demonstrated that the initiation of enzyme replacement therapy later than 2 years after diagnosis had an effect on the incidence of avascular necrosis. That's an important bony complication for patients. It shows us the importance of prompt diagnosis and appropriate evaluation and treatment. And of course, I should mention the therapeutic goals paper, probably one of the most often quoted papers in Gaucher disease over the last 20 years. This gives us an opportunity to use this registry analysis to try to benchmark the outcomes for our patients across a range of parameters. But even with our significant armamentarium of treatments, there are still disease management challenges. There's the ability to treat neuronopathic Gaucher disease, to find an agent which crosses into the brain and affects the changes which occur in type 3 and type 2 Gaucher disease. And similarly, there are disease management challenges for bone, with bone turnover being slow, some patients being affected in the bones with irreversible bone disease even before the start of treatment. For some organs, the challenge might be the penetration of the agents into the tissue. That might occur for bone and also for the lungs, which do affect or are affected in some patients with Gaucher disease. And similarly in the lymph nodes, which can be a particular problem for people who have neuronopathic Gaucher disease, often having a large accumulation of lymph nodes in other organs in the body. Currently, our treatments address the accumulation of substrate, may not so much address some of the end-stage changes, and perhaps that's somewhere that we should be investigating. They may not address other cellular mechanisms of disease, and this also opens up other opportunities for exploration for new therapeutics. But we do have a therapeutic choice which is increased. There's a possibility through therapeutic goals of an individualized regime. There's better supportive care, and we're learning how to share protocols and expertise through the IGA and IWGDD. There are new treatments on the horizon and currently in development. We have venglustat for adult Gaucher disease type 3 and Gaucher gene therapy under active evaluation. So over the last 30 years, I think we have had increase in awareness, which enables early diagnosis, better diagnostics, which have become more rapid, available and precise, better delineation of phenotype to allow classification, prognostication and stratification, understanding of pathophysiology coming out of that phenotype, and this can drive therapeutic advances and facilitating further understanding of how we measure outcomes. And this in itself is invaluable to developing better therapies for our patients, which I truly hope over the next few years will continue to improve, become more convenient, affordable, effective and safe, and available widely throughout the world to all of our patients with Gaucher disease. So thank you for this opportunity to reflect on some of my highlights that have occurred in the development of Gaucher disease over the last 30 years. Happy 30 years to the IGA, and congratulations on all that you have achieved and all that I know you will go on to achieve for patients and families with Gaucher disease.